anesthesia practice is monitoring during perioperative period and in intensive care unit. American Society of Anesthesiologists and Associations of Anesthetists of Great Britain and Ireland have mandated minimal monitoring such as pulse oximetry, NIBP, ETCO2, ECG, and temperature monitoring. But advancement in technology coupled with rising numbers of medical litigation has resulted in an increased demand for better monitoring systems. Thus, today's theme of academic is newer gadgets versus basic monitoring tools in anesthesiology and intensive care. How do we strike a balance? At the outset, I convey my heartfelt gratitude to the patrons of our society, Dr. Avtar Singh Sir and Dr. Tej Kaul Sir, and the webinar patrons, our very own Dr. S.P. Sharma Sir and Dr. Naveen Malhotra Sir, for giving me this opportunity to organize the scientific program. I also convey my heartfelt gratitude to the esteemed faculty who have joined this webinar in spite of their busy schedule. I am thankful to all the GC members for their kind support and guidance whenever it was needed. My sincere thanks to the delegates, including postgraduate students, for attending this webinar series. I welcome you all again. I would like to request Dr. Naveen Malhotra Sir to say a few words before starting the scientific session.
Thank you, Madam. Heartiest congratulations to RSACP West Bengal State Branch for organizing this academic webinar. And Madam has rightly said, this is the last webinar only of the year and the decade. But these academic programs will continue in the new year also, yes, and in the next decade also. And I am very happy to share with you that our annual National Conference of Research Society of Anaesthesiology Clinical Pharmacology will be held online in the first weekend of March 2021, 6th and 7th March 2021. So you are cordially invited. Also, the academic programs will continue in the new year also. Since last 6 months, 1st July onwards, we have been regularly conducting quality academic programs under the banner of RSACP every fortnightly by different branches across the country. And this trend will continue, and we will definitely have good quality academic programs. Before I hand over to my president, Dr. S.P. Sharma sir, I congratulate Dr. Sarbri Swaika, Vice President RSACP, for organizing a very nice program and a very interesting topics are lined up. Best wishes to the state branch. I also put on record my appreciation and gratitude for the faculty, without whom any academic program loses its sheen and nature. So best wishes and thanks for joining us today in the academic program. Long live RSACP.
Thank you, sir.
I request Dr. S.P. Sharma sir to say a few words.
Yeah, good evening. For patron of RSACP, Dr. Kaul, past president, Dr. Avtar Singh, all office bearers, all speakers, chairpersons and participants. I welcome you all in the webinar organized by the West Bengal State Branch of Research Society of Anaesthesiology, Clinical Pharmacology. I really congratulate Dr. Sarbri Swaika, Organ Chairperson, Vice President of RSACP, and Dr. Kasturi, Scientific Coordinator, and their whole team for continuous interest in the webinar organizing. And at this time also, they are organizing a very good webinar on this topic. You know that in today's time, many new gadgets are available now in the market for anesthesia practice and ICU practice. Like you can say wristwatch for the SpO2 or this measurement of blood pressure by fingertip or like that way, ECG and Android, all these things. But will these are as good as our basic monitoring system or devices? So today's webinar will have you good discussion about all this, and you will learn a lot. You will be updated with these things. I welcome all speakers, Dr. Harsh Sapra from Vedanta Medicity, Dr. Tushar from the Gujarat, Vadodara, Dr. Devanjali Rai from the Varanasi, Dr. Sandeep Sahu from the Lucknow, and Dr. sedation Kundu from the Kolkata. In fact, now this RSP is involving as the Pan India speakers and involvement of everybody. So what I would like to say that we are organizing very good academics webinar, and or you can say that now everybody is well appreciating this RSAP, especially in the Rajasthan and the West Bengal also. It is in good presence. So thank you very much, Dr. Saika, and I also welcome all chairpersons who will manage these sessions in such a way that there will be good interactions. I thank you to all our participants. They will definitely updated with the knowledge. And with this, regards to everyone, thank you very much. Happy New Year. Long live RSAP.
So can I start now, the scientific session?
Please, madam.
Yeah. So thank you, Dr. Sharma, and thank you, Dr. Naveen Malhotra, sir, for your kind words. And now we will move on to the scientific session, which will be conducted by Dr. Kasturi Hussain Bandopadhyay. She is the Senior Consultant and Academic Coordinator of DMD Training Program at Medica Super Speciality Hospital, Kolkata. She is the instructor of BLS, ACLS PALS of American Heart Association and PPLS of Asian Society of Pediatric Anesthesiologists, and also the instructor of PALS, BLS, CCLS of Indian Resuscitation Council courses. Presently, she is the EC member of IPA Bengal and active member of IDA Kolkata branch. Her area of interest are head and neck surgeries, acute pain management, pediatric anesthesia, and resuscitation training. So over to Dr. Kasturi. Please start the scientific program.
Thank you, ma'am, for your very kind and inspiring words. Good evening, everybody, and I welcome you warmly on this chilly winter evening. Before we wind up this year, to the academic webinar of RSACP, and I can assure you that as the discussions unfold, we will be getting exposed to information and updates from our honorable esteemed faculties. Thank you so much once again for joining us this evening. Going to the first topic of this webinar, intensive care sedation, role of anaconda and MIRUS. Well, inhalational sedation has actually popularized after the introduction of the anaconda system, which is very compatible with the intensive care ventilators which are being used. And another new system called the MIRUS system has been famous because it uses the desflurane without the circle system via an anesthetic reflector. So I am proud to have, we are all in fact proud to have Dr. Harsh Sapra as the first speaker on this topic. And we are indebted to Dr. K.K. Mubarak and Dr. Anil Verma to accept the invitation to chair the session. Dr. K.K. Mubarak is the professor and HOD of Anaesthesiology, Government Medical College, Kozhikode. Sir has served the post of Secretary ISA Thrissur and Kozhikode and has more than 20 index publications to his honor. Sir is the editor-in-chief of Indian Journal of Anesthesia and Analgesia and has started the Calicut Anesthesia Academic Program. Welcome on board, sir. Dr. Anil Verma presently holds the chair of Professor and HOD of Anaesthesiology, GSVM Medical College, Kanpur. He is the president of RSACP UP State branch and the president-elect of ISA UP State. Sir has more than 20 national and international publications to his credit. We welcome you, sir. I would request the chairpersons to introduce Dr. Harsh Sapra, and then the talk can begin. Thank you so much, sir. Over to the chairpersons, please.
Good evening.
Yes, sir.
Thank you.
Dr. Mubarak.
Yeah. I'm really honored to be part of this esteemed webinar by the RSACP run by the West Bengal unit, and I thank Dr. Kasturi and Dr. Sarbari Soiga for inviting me and allowing me to be in part of this webinar. And the theme selected is new gadgets versus basic monitoring tools in anesthesiology and intensive care. How do we strike a balance? And the first topic selected is use sedation, role of anaconda and mirrors. The speaker is Dr. Harsh Sapra. Sir is the director of the neuroanesthesia division of Medanta Medicity from, and Sir has done UG and PG in Aligarh Muslim University. Though I have not been personally interacted with Sir so yet, going through the biodata, I think he is the right person to have this topic to be presented, because he is basically dealing with the neuroanesthesia and critical care. And regarding the topic as such, the ICU sedation and is the the sedation part of in the critically ill patient is a crucial part in the management, and we are all using intravenous sedations and all those things, propofol, ketamine, and other sedations, but the using inhalation anesthetics is not much popularized, and it has come to the scenario, and anaconda and mirror systems are the newer ones, and I think we will be enlightened by Dr. Harsh Sapra regarding the newer gadgets in the ICU management using these newer techniques using inhalation agents. Over to you, sir. And I think over the next chairperson we may have something to tell, Dr. Anil Verma.
Can I start?
Dr. Verma. Dr. Sapra, sir, can we start the presentation?
Thank you. I thank the organizers and the office bearers for inviting me for this crucial talk. If you allow me to share the screen, I will share the screen now.
Sir, please go ahead, sir.
Is the screen visible?
Yes, sir. Yes, sir, it's visible, sir. Thank you.
Can I start with the permission of the chairs?
Yeah. Please start, sir. Please start, sir.
So good evening, everyone. So the topic allocated to me today is intensive care sedation, the role of anaconda and the MIRUS system. So anaconda system has been used by a lot of us, but MIRUS is still a emerging system which is primarily used in Germany, and we haven't had our hands onto the MIRUS system as yet. So first of all, it takes me to the basic question, why do we need sedation? Obviously, sedation is needed to improve patient comfort, decrease pain and anxiety, improve ventilator synchrony, facilitate nursing care, enable invasive diagnostic or therapeutic procedures, and it's neuroprotective in ways in the acute setting, especially in neuro ICUs and where the patients are injured, and traumatic brain injuries and comatose patients. And it also reduces sequelae such as post-intensive care, syndromes. So current sedation practices are predominantly, we rely upon benzodiazepines or propofol or ketamine. And commonly we use pseudoanalgesia along with opioids. Here in India, we use a lot of fentanyl and morphine. In the West, a lot of fentanyl and sufentanil is fentanyl and remifentanil is also used in ICU sedation. So obviously there are advantages and disadvantages of everything. So obviously benzodiazepines are widely available, inexpensive, familiar to the critical care professionals. But obviously the disadvantages include impacting the awakening times, duration of mechanical ventilation increases, hemodynamic stability, and perhaps maybe some change in the mortality. And prolonged and heavy use may promote withdrawal or delirium or tolerance and long-term neuropsychiatric disorders, along with prolonged use of benzodiazepines. Propofol is a very good agent. We all use it day in and day out, but it has its own pitfalls, causing hemodynamic instability, hypertriglyceridemia. It also can induce the PRESS syndrome. As regards the new drug which we've been using for a while now, dexmedetomidine, highly selective alpha-2 receptor blocker, increasingly being used for ICU sedation, although it's not a very good analgesic, but is used for conscious sedation and sedation. It can cause tachyphylaxis, and obviously it causes dose-related bradycardia, some amount of hypotension, and agitation with abrupt discontinuation of the drug. Fentanyl we all use as for analgesia. It does not allow for a rapid onset and awakening, and obviously depression of the intestinal motility can interfere with early enteral feeding with fentanyl. So it's time to look at the other way. We've all been going that way, but now it's time that we should look the other way. So my questions are: volatile agents the next thing for sedation for patients in intensive care unit? They have rapid onset and offset of action, no significant tolerance or tachyphylaxis or withdrawal, drug clearance via the pulmonary exhalation, largely excreted by lungs, independent of liver and kidney elimination, which may be an important consideration in patients with end organ dysfunction, and no alteration to renal or hepatic lab markers. Also, that they do have anticonvulsive effects, which are very beneficial to me as a neurointensivist. When I use the volatile anesthetics, primarily act on the cerebral cortex, depressing the sensorium, even at low concentrations, and leave autonomic functions like temperature control and blood pressure regulation undisturbed. So sevoflurane in low doses concentration prevents encoding of emotionally disturbing information, which can be a major cause of post-traumatic stress disorder as well. So what's holding us back? The use of volatiles in ICU is still off-label, and specialized medical licensing is still lacking. Technical challenge of needing large anesthesia machines, scavenging systems to minimize atmospheric pollution, and limited familiarity of this class of drugs among the intensivists is something which is lacking. So here comes the role of Anaconda. So this is in 2005, the anesthetic conserving device Anaconda, initially designed in Sweden, was marketed for ICU sedation with volatile anesthetic agents. So this is one of my patients with status epilepticus, where I use the Anaconda. So here what we have is a patient connected to the, this I'll go step by step, is the flu-sob. Flu-sob is the flu-sob where it absorbs the carbon dioxide, then the flu-sob accessory kit, as we see here in this figure, is it connects to the ventilator, and then the gas sampling line, which goes to the gas monitor, and the Natalon line goes from the syringe to the Anaconda device, where it pumps in liquid isoflurane, and this is the Anaconda device itself, and the Anaconda syringe is here. So here we have set up the system here, where this is the monitor with the isoflurane. You can see the MAC and the inspiratory expiratory values. This is the flu-sob. It's connected to the patient, one to the gas module and one to the evaporator there. So I will play a small video as well here. It's a 3-minute video, which will show you how to So this I have borrowed from the marketing people of Anaconda in India. So as you see, this is the system where the flu swab, this is a special device. So if you see, we are connecting it to the ventilator, the flu swab is being connected. So that's Dr. Atul Kulkarni from Tata Memorial. So it has vents there. The flu swab goes onto the ventilator. This is a special device to fill, goes onto the isoflurane bottle so that you can fill the isoflurane with a syringe. It goes onto the bottle like this. And there's a special adapter. So with this adapter, you can fill in the isoflurane. So be sure you don't leave any bubbles in the isoflurane syringe. I'll tell you why in a short while. So it generally requires a bolus of the dead space of 1.5, which is the length of the tubing. So that's the device, Anaconda device. So that's your sampling line. So your HME filter comes off and the Anaconda goes on. Anaconda has a inbuilt HME filter as well, so you do not require a HME filter along with the Anaconda. The reflector and the HME filter are there in the device. So as you see, generally it would last you 24 hours. So that's your sampling line onto the monitor. So 1.5 bolus is enough and is starting at 2 mils an hour after the bolus been given. Then you can see the patient nicely sedated. Okay. So moving on. So Anaconda uses a specific anesthetic reflector to reduce anesthetic agent wastage. The reflector inserted between the Y piece of the breathing circuit and the patient, as I showed earlier, is similar to a HME and takes 90% of the exhaled anesthetic and resupplies this during the next inspired breath delivered by the mechanical ventilator. It has an internal dead space of around 100 ml. So obviously it can be used with standard ICU ventilators. And a syringe pump continuously infuses liquid isoflurane or sevoflurane into a miniature porous hollow called the evaporator, which is at the base of the Anaconda device. That converts the volatile anesthetic agent from liquid to vapor state before inhalation. And activated carbon fibers interwoven in the HME serve to adsorb, store, and release the anesthetic vapors. A sampling port from the Anaconda device allows the expired gas concentration to be continuously displayed on the gas monitor. Once the monitor detects the anesthetic agent in the expired air, the infusion rates can be titrated to achieve the desired level of sedation. For sedation, the end tidal anesthetic gas concentration should be slightly more for 1/3 of the MAC, so slightly more than MAC awake, I would say. And for isoflurane, a good rate would be between 2 to 5 ml per hour, and for sevoflurane around 2 to 6 ml per hour to provide acceptable sedation. You can titrate it downwards up or upwards down as you please. The reflecting system of the device is 10 ml of anesthetic vapor contained in one expired breath, so of approximately 1% volume. Therefore, the infusion rates of the volatile agents need to be increased if the minute ventilation is increased, and the resistance is not more than any other HME filter, standard HME filter available in the market. So device-specific 50 ml keyed color-coded syringe is there. The syringe barrel and plunger are made of polypropylene, while the piston is made of rubber, so that isoflurane, sevoflurane, once they are given, they do not. Normal syringes would lead to some contamination, so that's why a special syringe is provided along with it. Isoflurane and sevoflurane are drawn from their container bottles into the 50 ml syringe with the special adapters which I showed, and are perfused continuously in the evaporator rod, independent of the respiratory cycle. So the manufacturer recommends a device change after 24 hours, but it also depends on at what rate are you running the device. We have used it for approximately, although the manufacturers don't recommend, but we have used it for 40 hours in patients of status epilepticus. Other plastic syringes and extensions must not be used, as the volatile agent may dissolve and produce potentially toxic products. So the reason I was telling you that there shouldn't be any bubbles in the syringe, because the liquid anesthetic agent will evaporate into the bubbles, making them grow. And do not fix the pump high above the patient's head. The reason is this may lower the boiling point inside the syringe and can cause the growing bubble to the pump in the liquid anesthetic bolus into the device, a feature called auto pumping if the bubble increases. So make sure that they are lower than the head level, and secondly, there aren't any bubbles in the syringe. So dead space, I said, was 100 ml, so it's limited use in the pediatric population, and patients receiving lung protective ventilation, low flows, surfacing from respiratory distress, or suffering from respiratory distress, or presenting with high secretion load, the device is not an ideal device for these subset of patients. So ambient pollution, obviously 10% of the vapor gas still needs to be scavenged. This is done by the flue sob, and Anaconda plus scavenging releases only 2 to 4 ppm into the atmosphere, which is well within the US regulatory regulations for anesthetic gas and generally considered quite safe. Desflurane cannot be delivered by the Anaconda. This is because of the low boiling point of desflurane, meaning it cannot be administered using a syringe pump as is required by the design of Anaconda. So for that, we have another device called the Mirus. Mirus is not widely available. It is a device which is introduced in Germany, and the new Mirus system is the first to use desflurane with the anesthetic reflection instead of a circle system. So we haven't had our hands on to the Mirus as yet. I am not sure whether it's still available in India, but I haven't used the Mirus, but it is available in Germany. So it offers an automated end expiratory target controlled application of volatile anesthetic irrespective of breathing parameters set on the ventilators. Unlike the Anaconda, the Mirus delivers anesthetic and monitors gas concentration as well as the ventilator parameters on its own. It also offers target controlled end tidal anesthetic concentration, as you would see with the vaporizers in the theater machines. So it has something similar, a Mac Pilot, which is a machine which is special features of Mirus, a control unit which has monitors and it controls the gas flow, pressure, volatile concentrations, and application. An exchanger, which is volatile anesthetic carbon reflector, and a exchanger is inserted between the Y piece of the ICU ventilator and the tracheal tube and connected to the control unit by a special multi-lumen cable, which would be connected to one end to the Mirus control unit and to the other end to the exchanger. So this is the Myrus exchanger, Myrus reflector, and the Myrus filter. It goes on to the Myrus controller, and obviously this goes on to the ventilator. So environmental safety, obviously ambient room pollution was minimal in most cases, and the measured value were within or below the recommended exposure limits. Only caution which was given was while filling the Myrus system. Clinical trials using the Anaconda device, obviously time of extubation was much less than in midazolam. Time to verbal commands was much less. Time to target sedation was more or less comparable. Opioid requirement was less in the isoflurane group, and there was no difference in patient mortality. Isoflurane sedation was initiated in patients who require increased doses of midazolam in this particular study to meet the desired sedation level. Compliance was achieved quicker with isoflurane. Wake-up time was significantly shortened, and sedation costs were lower if you compared to what was required with other agents, IV agents. Sevoflurane sedation with Anaconda device. It's a child undergoing extracorporeal membrane oxygenation. Anesthesia using sevoflurane is efficient for children undergoing ECMO. This was a study which was done in France. I don't know whether it is, I think it is limited to a couple of children, so they have just used it as a trial device. NICE, the British organization, Anaconda for sedation with volatile anesthetics in intensive care, have come out with a publication on 6th of October this year. So there are 5 studies summarizing this in brief. The published studies on the original Anaconda device suggest that sedation with volatile anesthetic using Anaconda is effective. 2 of the studies showed reduced extubation time, and 1 showed reduced length of intensive care stay where compared to IV anesthetics. So another study in 2017, study design and location of 610 patients, 8 studies, intervention and comparer. Intervention: inhaled anesthetic, isoflurane or isoflurane or sevoflurane through Anaconda, compared with IV anesthetic with propofol or midazolam. So times to extubation after intensive care admission or stopping sedation were 74 minutes and 76 minutes. So, 74 minutes and less in patients sedated with volatile anesthetics. There was no difference found in the length of intensive care stay, and patients sedated with volatile anesthetics had lower trop-I concentrations, so might be suggestive of reduced cardiac damage with these volatile anesthetics. I'll skip this particular study. So I'll go to the sustainability. Studies show that Anaconda is environmentally safe in an intensive care setting and reduces isoflurane consumption. This reduced consumption is important because volatile anesthetic vaporizers, including isoflurane and sevoflurane, contribute to global warming. So potential impacts and expert views: that device could be life-saving in acute asthma. Volatile anesthetics use could lead to potential improvement in lung inflammation and gas exchange in ARDS. It can be used to manage sedation in difficult circumstances, if IV, difficult IV excess, managing delirium and treating withdrawal, providing sedation where there's difficult or limited IV access, treating patients with history of alcohol abuse. And particularly in my case, I use it a lot in status epilepticus, where patients are not able to step up therapy of 4 or 5 anti-epileptics, and along with it midazolam, propofol, and even ketamine. So vaporizers, initially we used to wheel in the machine from the theaters, but now we've started to use Anaconda, and I tell you, volatile anesthetics work magically in status patients. Waking up times are faster using volatile anesthetic agents, and using volatile anesthetic enhances the ability to make neurological assessments, which is useful when assessing brain injuries. So there are some recent ongoing studies. These are studies ongoing in France, where assessment of this device, novel methods of non-invasive sampling of distal airspace in ARDS with received inhalational sevoflurane. There's another study, sevoflurane for sedation in ARDS, again still recruiting and ongoing in France. And this one is another study where they are randomized control open label study to confirm the efficacy and safety of sedation with isoflurane in invasively ventilated ICU patients using the Anaconda device. This is ongoing in Germany. Interestingly, it has been studied in COVID as well. The study is still ongoing in France. The Anaconda device is being used, and this study is ongoing as well. So Mirus with desflurane was used for 24 hours in a patient suffering from ARDS. This is another study of Anaconda and Mirus, where they used it concurrently in the same patient. Sedation was switched on the day 4 from midazolam sufentanil to desflurane administered via the Mirus, and sufentanil was decreased from 0.95 to 0.38 mics per kg per hour. Thereafter, isoflurane was applied with the Anaconda and the Vemos gas monitor. So the findings were awakening and washout were considerably shorter than after isoflurane in the same patients with Anaconda. However, the consumption of desflurane was high. So they concluded that desflurane sedation with Mirus seems promising, but the reflector needs to be improved to absorb and adsorb and resupply more of the anesthetic agent. I'll just skip the study. And so in a nutshell, ideal ICU sedation continues to be an elusive goal. The need of the hour is to adapt to the newer modes of sedation that allow for rapid titration, faster wake up, and extubation and discharge. With excellent pharmacokinetic and favorable side effects, volatile anesthetic agents can prove to be a game changer for ICU sedation, resulting in improved patient care and outcome. Anesthetic consumption using the Anaconda or Mirus device has been shown to equivalent to that of conventional circle system. Pure drug costs have also been shown to be either less or comparable to the conventional IV agents. More importantly, patients receiving volatile anesthetic for sedation spend a shorter time on ventilator and could be discharged home faster than patients on conventional IV sedatives. So with this, I thank you all with this cartoon saying opportunity is missed by most people because it is dressed in overalls and looks like work. Thank you.
Thank you, Dr. Sapra, for a very lucid and informative talk. We are open to questions from the chat box. So can we start, sir? Can we start, Dr. Sapra? The first question is, where is the FluZorb attached? Well, you did mention it at the beginning of your talk.
I showed it
yes.
on the video as well. It's attached to the ventilator.
Yes.
One of the ports on the exhalatory port.
So how do you ensure that the extension line from the syringe pump is not connected to IV by mistake?
How do you, sorry?
How do you ensure that the extension line from the syringe pump is not connected to IV by mistake? That's what.
Sir, I think that has to be ensured by the person using it. There is no way to ensure that it's not wrongly connected, because it would, if you put it IV, it would go IV. So it has to be unfortunately ensured by the operator that all things are connected properly. So the users have to get used to using it, and it has to be the same team who uses it time in and time out.
And the next question comes, for how long the inhalation agents can be used for ICU sedation?
Sir,
Like
we have used, in a status patient, we have used isoflurane for 20 days. That's the maximum I have used it. but generally, the patients respond immediately. Say if I talk about a suprarefractory status epilepticus, lot of 50% of the patients would have a isoelectric EEG in say 20 to 25 minutes. But sometimes on withdrawal of the anesthetic agent, the seizures start reoccurring again. So you have to wean them slowly as well. Majority we would get off in 2-3 days, but for this particular patient we've used it as long as 20 days. And we monitor the usual LFTs and the usual RFTs and usual things when we.
And so then the next question has come as cases where the use of Anaconda provide benefit over other methods.
Mm-hmm. Sir, so it would be beneficial, especially in cases of refractory status asthmaticus, status epilepticus. These would be two key places where I would use it. Because as we all know that even in anesthetic in our theaters as well, bronchospasm is cleared very, very quickly with increasing the vapor on the vapor flow. And similarly, we have used it in status epilepticus as well, where we use isoelectric EEG fairly quickly, where all IV agents and anti-epileptics are not working. So these would be my two main places of interest where I would use it. Rest, I think I am not sure, although the studies do show that it is cheaper than IV, but in my experience, it doesn't turn out to be cheaper if you look at the cost of IV anesthetic agents in India. So maybe there are international studies, the IV anesthetics are more expensive there, but in India, I think it turns out to be dearer. But at the same time, these are the clinical conditions which have certainly shown benefit with the Anaconda device.
I think that the next question has already been answered. Can it be used in prolonged ventilation? I think you have answered it already. And what about the toxicity of volatile anesthetics?
So they are exhaled, and so we haven't noticed any problems using it for longer periods as well.
Sir, I would like to ask one question. Can you use like vaporizers? Are there agent-specific Anaconda equipments, or can you use the same thing in isoflurane and sevoflurane, the same equipment?
Same Anaconda can be used either with isoflurane or sevoflurane, but Mirus can use desflurane as well. Desflurane cannot be used because of its boiling point. It cannot be used in an IV syringe. But Anaconda can be used for the two agents, and Mirus can be used for all the agents actually.
Is there approximate cost of the system Anaconda in India? Any idea?
Sir, Anaconda, the whole system, including the device and the flu swab and the syringe, the whole system costs around 20,000 rupees. The adapter for filling the drug is provided by the company, but the adapter itself for the drawing syringe is a special adapter that costs around 25,000 rupees, but that is a one-time thing which the company gives it to you once you start using the Anaconda. So
you find it cost effective.
So the Anaconda itself needs replacement after 24 to 48 hours, but the flu swab can go up to 90 hours or say 90 hours or I would say, approximately 72 to 90 hours. So Anaconda needs changed after 1.5 days, and Anaconda, the reflector would cost you around, I think it's 9 or 11,000 rupees.
What's the running cost?
Running cost is the same, sir. You just need to have the same ventilator and the same syringe. It runs at 2 to 3 mils. Isoflurane runs at 3 mils an hour. Isoflurane is pretty cheap, so running cost is not much, sir.
Okay, then those questions already come here. Then has Anaconda tried to incorporate feedback system into software where we just have to adjust the MAC value and other things are done automatically even with changing minute ventilation? That's a question.
Anaconda is a manual device, so it's the other way around. You have to look at your MAC and increase or decrease the isoflurane flow rate between 2 to 5 ml in isoflurane, not the other way around. It is not a computerized system where the MAC would be controlled automatically, but the Mirus can do that. But then there would be an initial cost for the equipment of Myris as well, as you compare it to the Anaconda. It's a more of a manual system where you have to do the things yourself.
Okay, sir, thank you. Those are the questions which has come in the chat box.
Thank
Yeah,
you,
over to Dr. Kasturi.
Dr. Verma,
Dr. Sapra.
Dr. Anil Verma, sir. Yes, can you put in your request?
Good evening, Dr. Kasturi.
Good evening, sir.
Good evening to Dr. Sarvari, Dr. Malhotra, sir. Good evening. And because I just joined the session a little 5 to 6 minutes late, Dr. Sapra is quite interesting the use of Anaconda, because I am quite fond of this sedation, specifically in the intensive care. My two queries. One, that you have used this Anaconda for the sedation purpose for the two particular patients, what with the status epilepticus and status asthmaticus sort of.
Sir, I said that the two main indications, but I primarily use it for status epilepticus.
Status epilepticus. So if the patients are being intubated and put on the ventilator, so you use it as a sole agent for the sedation, or you use analgesic along with it, because the analgesia itself is a component for the sedation intensive care.
That's what I showed in the studies as well. So we have noticed, see, the two things, sir. For status patients, a lot of analgesia is not needed. They're not trauma patients, or they're not patients who would require high doses of analgesia. They would require interruption of their seizures, as regards through sedation or through anti-epileptics. So we do not use Anaconda as the first step. Obviously we exhaust our options with our agents. You have a step-up ladder where we would use 3 to 4 anti-epileptics. We would use propofol infusions. We would use ketamine. So we decide as per with the neurologist and the continuous EEG whether to use inhalation. If they're not subsiding with anything, we have seen good results with isoflurane. Previously we used to bring in the machine from theater, although scavenging wasn't, it's not ideal, but we use Caesar cessation with volatiles. With advent of Anaconda, that problem's solved as well, where we can have the scavenging as well, Flusoft can absorb it. So as regards sedation, it provides very good sedation and cessation of seizures. Analgesia, we do run fentanyl with it if analgesia is required, but the dose of fentanyl also decreases as compared to other IV anesthetic agents, and that's been shown in studies as well. But honestly speaking, we require very little analgesia in our status patients per se.
Probably that's all about the questions, is it, sir? The chairs, please. Dr. Mubarak, Dr. Verma. Any more discussions, or can we go on to our next topic?
Yeah, I think we have overshot the time schedule, I think.
Yes. Thank you, Dr. Sapra. It was a very lucid and extremely informative lecture and very fruitful discussions. Thank you. So we move on to our next topic.
Okay, ma'am.
Thank you, sir. Groundbreaking advances of gadgets in anesthesia practice. Technological advances in the last several decades has actually revolutionized the monitoring technology, gadgets, tools, as well as their clinical applications. And not only in patients who are being cared in the perioperative period, but also for patients who are cared in the intensive care unit, and even ambulatory patients. So, and they have all collectively built up a very good quality improvement for patient care. We are very proud and honored to have Dr. Tushar Chokshi as a speaker for this talk. And we are incredibly pleased to have Dr. Ashok Kumar and Dr. Naveen Malhotra with us as chairpersons for this session. Dr. Ashok Kumar, sir, is a professor and HOD of Anesthesia, Nalanda Medical College, Patna. He is the ex-vice president of RSACP, ex-secretary ISA East Zone, and ex-president ISA Bihar Jharkhand branch. And sir has numerous publications in various national and international journals to his credit. We welcome you on board, sir. Dr. Naveen Malhotra hardly needs any formal introduction. Presently, the professor in anesthesiology and head of Department of Pain Management Center, PGIMS, Rohtak, Haryana. Dr. Malhotra holds the esteemed post of Honorary Secretary of RSACP National and ISA National, and it is needless to say that he has been leading us with unparalleled zest and enthusiasm. Good evening, sir. Please, we welcome you on board. We would request the chair to kindly introduce Dr. Tushar, and so that we can begin the next presentation.
Thank you, Dr. Sarbari Swaika and Dr. Kasturi, my respected Dr. Ashok Kumar, sir. And after a very nice talk by Dr. Harsh Sapda, thank you, Dr. Harsh, for joining us today and interacting us on a very new topic. After that, thank you, Dr. Harsh. And after that, we have got another great friend, Dr. Tushar Choksi, who shall be talking about another important and interesting topic, groundbreaking advances of gadgets in anesthesia practice. And Dr. Tushar Choksi is a person, happy go-to-lucky fellow, and always believe in exchange of knowledge. At present, he is working as a consultant private practitioner in Vadodara, Gujarat, and he has got 30 years of experience in TIVA, OFA, NORA, Euro anesthesia, lap anesthesia, ENT anesthesia, pediatric anesthesia, and he's also a visual storyteller and vlogger, and he's affiliated to numerous hospitals in Baroda, and he has been founder of TIVA and OFA Facebook groups in India. He has been invited as a speaker to numerous national and international conferences. He was instrumental in starting numerous smartphone and tele-anesthesia practices in India and infographics in anesthesia. That is his, I can say, we are regularly enriched by his infographics almost every week on one on another drug or technique. So we look forward to listening from Dr. Tushar Choksi on a very interesting topic. With the permission of Dr. Ashok Kumar, I invite Dr. Tushar Choksi to please start his talk.
Can you see my slides?
Yes.
Thank you, Dr. Naveen sir. And I am very obliged to give my topic on this from RSACP West Bengal branch. And today's my topic is on groundbreaking advances in gadgets in anesthesia practice. So there is first slide of disclaimer in my topic. This presentation is for medical information and knowledge. It specifies that it helps in medical practice, and the use of these innovative and newer gadget informations are subject to individual preference. Further, users are advised to seek professional medical assistance if they want to use. Now, I have classified these gadgets in 5 categories. There are pre-operative gadgets, anesthesia-related gadgets, operation theater-related gadgets, medical gadgets, and post-operative gadgets. Now, this presentation is more on pictures with short description of innovative gadgets. So, you enjoy this presentation. So first we will go with the very basic vital parameters, blood pressure. We have seen that our blood pressure instrument with multi-para monitors and everything. But you see in these slides, there are finger blood pressure monitor, wrist blood pressure monitor, cuffless blood pressure monitor, then wireless blood pressure monitors are available in the market. This finger blood pressure monitor with measures with only finger, wrist blood pressure monitor measures from the wrist, and this cuffless blood pressure monitor, this Taiwan company FreeScan, here the instrument can be kept on the radial artery and it directly measures the blood pressure. And this wireless blood pressure monitor from iHealth, this will give the results on our smartphone. Believe me, all these smart gadgets are available through the wireless or Wi-Fi or Bluetooth with the smartphone, or with the attachment through the audio jack or with the power jack. Then thermometer. See, this Medicina company came with this thermodoc infrared thermometers, and it is a smartphone attached. We have to attach with the this audio jack, and it gives the result in the smartphone. And these are the devices like the multifunction smartphone infrared thermometers are available in the market. It supports the human body, water, food, and environmental temperature testing. And the Kinsa company came with this smartphone thermometers. And the first one is for the pediatric patient. The beauty is that if the pediatric patients are put on this thermometer and it shows the smiley over the smartphone, so pediatric patient likes it. And this type of the thermometer, it comes with the attachment with the this smartphone, and this is for the adult. So it tells your temperature, offers real-time guidance on what to do next, tracks fever, symptoms, medications, and diagnosis for you, and sends your health details straight to your doctor and lets you know if fever is cause for concern. Then weighing scale. This is a typical weighing scale. It works with the Wi-Fi Core Smart Scale, and it measures the 9 aspects of your body composition with only medical grade scale. It measures weight, lean mass, body water, bone mass, muscle mass, BMI, body fat, visceral fat rating, and daily calorie intake. So it is a very useful for all these hospitals. Then we came with this pulse oximeter. We have seen regularly in this COVID pandemic finger pulse oximeter, but this is a ring pulse oximeter. Just like a ring, we have to wear on the finger, and it will shows in the results will be shown in this display. Then wrist pulse oximeter. Again, neonatal patients will be put in neonatal ICU with the neonatal disposable pulse oximeter. That is a wrist pulse oximeter, and this is a wireless pulse oximeter through Bluetooth. I am using this from iHealth since last 7 years, and I'm very happy. When I am sitting outside my OT, then I can see on my iPhone, this iPhone, through this app, my patient's SpO2. And this again another attachment. Another attachment from eye oximeter is available from the SafeHeart, where you can attach this probe directly on your smartphone, and it shows the result on this smartphone. Then even all the smartphone having a near field communication, this device, then pulse oximeter will be this can be seen by the NFC also, and it is coming in the market very soon. Now disposable probe, SpO2 probe, forehead sensor probes are also available in market. Even in tongue probes are also available in the weight anesthesia market. Then this BioBit company from Israel came with this wrist type of the watch, and this measures pulse rate, blood pressure, and SpO2 both. So it is very useful in all the patients who are on the post-operative period. Then Massimo company came with the oximeter to measure respiratory rate in children and adults. So it measures SpO2 plus respiratory rate from the plethysmograph. And Massimo again came with the oxygen reserve index. It measures the oxygen reserve index, but it nicely gives the advance warning of the impending desaturation in these machines. Then people came with the first response monitor. It tracks the heart rate with respiratory rate in multiple trauma patients. It is just a nose clip, like it clips onto the nose and immediately begins the monitoring, and it shows the heart rate plus respiratory rate. Then people came with the smallest size of the, like smartphone size of the handheld pulse oximeter with blood pressure, like PM50 ambulatory, SpO2 with NIBP, and Quantica 08 digital blood pressure monitor with SpO2. People also came with the handheld pulse oximeter with capnograph, like Burton's and Smith Medical. They came with the very small instrument, like again smartphone size. This attached with this even in smartphone also, and the smartphones like instruments, and handheld pulse oximeter with capnograph. Then if you are fed up with your regular stethoscope, then these are the smart stethoscopes are available in the world. The first stethoscope is Vioscope. This is a smartphone enabled stethoscope approved by FDA. Then this is the smallest powerful ThinkLink. Just plug in and practice. This is the smallest size of the stethoscopes available in the world. Then people came with the Ecoro, where the machines could be put on the patient's chest or backside of the chest, and the results will be shown in your iPad or in smartphone. Then this Cambridge Medical came with the Ecoscope, which shows the integrated electronic stethoscopes and electrocardiogram in the same stethoscope. And Japanese people came with the U-scope. If you are fed up with your routine stethoscopes, then it is a completely redesigned stethoscope for improved ergonomics. It reduces the pressure on the ears and comfortably fit while wearing it. Now, if you go to smartphone ECG machines, then this is a AliveCore Cardia mobile EKG. I am using since last 5 years this EKG, where we can attach 2 pads on our smartphone backsides, and we can take this from our palm with EKG on our smartphone. Then people came with the smartphone Cardio Defender. It is a world first ECG system which delivers hospital-based quality ECG and arrhythmia analyzed by the integrated unique smart software. And this is Mobmon, available in 75,000 rupees. It is a smartphone-based 12-lead ECG machine and with pulse oximeter. Then this is a smart defibrillators. This is Australian company Indiegogo came with this smartphone defibrillator. Here the beauty is that it will go in AED mode as soon as the two pads are pulled out from the backside of the smartphone case. And it immediately dials the country's emergency number, and it gives locates the locations, and it gives the instruction to the rescuer. And this is the from Lateral company A4 size defibrillator, and it works on the Bluetooth wireless transceiver module and smallest and textbook size. It works on the presenting VF, and it determines the initial therapy, whether we should give shock first or CPR first. And these are the implantable defibrillators, which are the even the heart attacks or cardiac arrest is there, then it gives the defibrillation from the inside the body. Then this is rescue CPR system, where two parts are there: rescue pump and rescue POD. The rescue pump delivers optimal chest compression on every stroke, and rescue POD used by another person delivers proper amount of air to oxygenate. And this is a quick spice. If there is bad things, then if the patients are arrested during intubation or extubation, then cricothyroidotomy, it speeds up the process and leaves less room for the error to speed up the cricothyroidotomy. It then breaks up to reveal the port through which an endotracheal tube is inserted. The beauty part is that it is a very simple instrument to use, and no need, it will be finished within 1 minute also. And these are the smart glucometers. Now again, smartphone is used as this glucometer, glucose monitoring system. It works wirelessly with smartphone. Again, this iHealth company came with this, and these are the attachments are available in the market from Amazon. It are hardly cost 500 to 600 rupees. And this is a glucose-wise. This is non-invasive blood glucose concentration to be measured at the capillary level. The glucose levels are extracted by a non-invasive technique. It utilizes two unique technologies: high frequency radio waves and integrated nano composite film. Here, no need to penetrate the skin by lancet. And this is a Dario glucometer. Dario is a warm colored gadget which includes much more than a regular glucometer, a lancing device to provoking a small blood flow, and it connects to your smartphone. Believe me, all these gadgets, what I am showing you, they work either through the smartphone, either through your any gadgets, or via software, or via Bluetooth, or via Wi-Fi. And this is a sugar bead. It is a pain-free, non-invasive. It is a continuously monitoring and small disposable patch painlessly stuck on the user's arms, leg, or abdomen. It measures the body's glucose level via the skin, connected to a small electronics sensor, and results shown in the watch like a smartphone, smart wristwatch. There is even not from the blood, we can measure the sugar from the blood. We can measure the sugar even from our tears also. So people came with the Novio Sense. It is like the flexible ocular insert for glucose measurement. It is a small and flexible spring-like device, 2 centimeter in length and 1.5 millimeter in diameter. Device measures minute changes in the glucose level in the tears that are representative of blood glucose level, uses wireless data. And the Google and with Novartis company came with the smart contact lens glucose monitoring. It measures continuous glucose levels in the tears by nanotechnology, and it is very useful in our anesthetized patients. And these are the smart spirometers. These smart spirometers, we can attach all these types of these instruments on our smartphone directly with the audio jack or this power jack, and it flawlessly connects to your smartphone so that you can easily see and share the result to the test. And this is the non-invasive hemoglobin measurement that is from Orsense, non-invasive blood analytes monitor. It works on occlusion spectroscopy. It measures blood hemoglobin, pulse oximeter, and pulse rate. And Massimo came with the RAID 57. It measures the oxygen saturation, pulse rate, perfusion index, and pleth variability index. And if it is upgraded with Pronto pulse oximeter, then it measures all sets of hemoglobin measurement, like this total hemoglobin, methemoglobin, carboxyhemoglobin, and total arterial oxygen content. And then Netanyahu-based company from Israel, TytoCare, came with this for pre-anesthetic checkup and telemedicine. And this small instrument, which is very instrument, and this device includes regular stethoscope, thermometer, otoscope, built-in camera, and tongue depressor. So it is very useful for the PAC and telemedicines. Then people came with the vital patch. It is a banded like disposable vital signs monitor, and shows result on a smartphone. It measures single lead ECG, heart rate, PR interval, respiratory rate, skin temperature, body posture, fall detection and activity including steps. So it is very useful in the ICU setups and the results will be shown in our smartphone or in the computer. Even our sweat will also measure the biochemistry and glucose level. So people came with the sweat sensor also. Then smart vein finders. Routinely we are using whatever the smart vein finders. If we are fed up, then Google came with the Google glasses, and even the ultrasonography guided this wearable infrared glasses for venipunctures are also available. Then there is a small instrument that is a tap at home blood collection system. It is very tiny, around 3 centimeter of size. It nearly painlessly collects the blood. The single-use device features micro needles that penetrate the skin without causing significant pain. And if you are giving injection intramuscularly to hemophilia patients or something like bleeding disorders patient, then self-sealing needles for preventing blood loss after injection. It is a biodegradable polymer coating that can plug an injection site called chitosan. And there is again valinovascular new needle-free blood flow device available. It's a new version of its needle-free blood draw device. The product is connected to a peripheral IV catheter and allows drawing the blood straight into syringe or attached vacuum tube. Patients already on a peripheral IV don't have to undergo traditional venipuncture. It's a very good innovation. Then there is a smart vein flows. Delta vein close system came with the peripheral IV catheter. It reduces the risk of the exposure to the patients. It contains the two ports with chamber and there's the lock system. It is available in wide range of gauge from 16 to 26. And this IV cannula with integrated 3-way is available in the market. So no need to go for extra 3-way stopcock. Then safety IV cannula with injection valves are available. When you insert a vein flow, then your needle goes straight away into your safety chamber. And this type of vein flows, when the needle comes out, and the needle tips are covered by the umbrella, so there is a safety needle in a vein flow. And Dr. Mahurkar, he is from Indian origin. He came with the Mahurkar smart syringe, and there is no possible reuse. The needle holder is locked to the plunger. After use, the entire syringe is interlocked. So needle will go directly in the plunger after injecting in the muscles. Then there is a smart adhesive bandage, 8-tack. They are waterproof bandages, come with the anticoagulant, antibiotic, antifungal, and wart remover. It releases a multi-compound therapeutic substance to the sterile pad. Then this is the anti-snore devices for the post-operative period. Patient for chin-up from Dupiaco company, chin-up type of this snore devices came. Patient's airway support device used for the MAC and TIVA sedation procedure. And in our even again post-operative period, if the patient is having very sedated, then anti-snore chin support straps belt are available on Amazon. It is hardly of 230 rupees. And this type of the smallest CPAP available in the world, that is a Airing. And they have got a inhalation port and exhalation port, and there is a housing. And the people came with the snore-free nose clips. It gently opens the nostril to increase airflow, and built-in magnet provides magnetic therapy, and it is a non-invasive. It is also around 200 to 300 rupees. Then in my gastroscopy practice, I have developed this type of the endoscope. I have seen this type of the endoscopy mouth guard and mask. This is a Ovesapien fiber optic intubating airway. This is a VBM endoscope mask. This will be attached directly to our trolley, and the gastroscope or fiber optic scope go through this. Then this is a OxyGuard oxygenating mouth guard. It is a unique oxygen nasal port. Here the oxygen ports are different, and we can give oxygen through this port. Easy and safe to use. It delivers oxygen to both the mouth and nose. It saves time, efforts, improves patient comfort, and it is a disposable. Then penis mouth guard for ERCP anesthesia. There are two ports, one port for the oxygen and a second port for the capnography. So this is a very good instrument for in the ERCP patients or with the prone position endoscopy for. And these are the endoscopy supraglottic airway devices are available. This is a LMA gastro airway, where one port is for the gastroscope and one port is for our tube connections. That is for our trolley. And this is again a laryngeal tube. That is also two connector, gastrolaryngeal tube, one for the scope and one for the endoscopy lumen. Then different nasal and endotracheal tubes are also available. Nasoflow company came with the Nasoflow and nasopharyngeal airway device. It allows for direct oxygen delivery. The beauty part is also that they have got an optional respiratory indicator with or without hyperbaric. So it can measure even the capnography also. Then Hylar microcraft subglottic suctioning endotracheal tube. That is, they have a separate channel for this, separate cup for this endotracheal suctioning. Then Endoflex endotracheal tube. No need for the stylet to introduce in this endotracheal tube. The distal part of this endotracheal tube will be flexed or deflexed around according to our laryngoscopy view. Then from Chinese company, one of the Chinese the scientists came with the nasal jet tube or nasal jet endotracheal tube. Both are very good for this and jet ventilation. Then 3M company came with the newly marketed Durapur advanced surgical tape. The new product enters the skin, various tubes, and to itself when its surface is moist, having different textures. In humid environment, the tape is designed to perform well. Up till now, we have seen the hinge type of the laryngoscope. This is the Macintosh switch style laryngoscope. So it is like a screw type. Then Rodinia company came with the Tilke-Magill's forceps for easier and safer nasotracheal intubation. So here the endotracheal tube will be catch very nicely. And for pediatric anesthesia, scented anesthesia mask available. It improves the patient's tolerance and reduces the children's pre-surgery anxiety. These are the different scents we can use with this anesthesia mask. Then for pediatric sedation, this Exxon sedation masks are available for dentistry and orthopedic surgery. And these are the scented masks designed to optimize the comfort and minimize the anxiety, lightweight and stays out of the way of the nose. There is no prongs, so it directly attach over the nose. And this is there is a unique system for Hello. There is a unique system to administer the patient outside the operation theater. It is a servo. The dragon uses fire breath to distract kids from the getting sevoflurane anesthesia. It is used during inhalation anesthesia induction. The beauty is that the childs are instructed to see on the TV screen, and he is given a sevoflurane mask. And when he is instructed to take deep inhalation or deep exhalation, at the same time that the dragon also exhales and inhales, and the childs are instructed to take the deep breath and deep inhalation or deep exhalation, then there's again this dragon will do that same job. So the child will enjoy and goes into sleep. And this is a SatLine monitor, children's brain under anesthesia from the Massimo. It assists the maintaining the proper depth of the anesthesia to prevent side effects while helping to improve post-surgical unit. These are the video laryngoscope, smart video laryngoscope. I have developed this smartphone video laryngoscope 5 years back, first time in India. It is an industrial boroscope, and I have attached with my smartphone. My smartphone works as a monitor and as well as light source, and very economical and easy to use. Anybody from any part of the world can use this type of the video laryngoscope in the initial period, and we can even in 500 rupees, this type of the Android boroscopes are available in the Amazon. And this is the first time laryngoscope with built-in suction. It helps to speed the patient's intubation, particularly benefiting in emergencies. And now the disposable video laryngoscopes are available in the market. And this is Anaesthesiology. It automatically keeps the endotracheal tube cup pressure at the right pressure. A system that automatically adjusts the pressure of endotracheal tube cups. Then the rapid positioning intubating stylet. The new type of stylets are available. It dynamically intubates the stylet with controlling tube which can flex and retroflex. From this catch, we can flex and retroflex the endotracheal tube end. And these are the smartphone USC machines are available. This is the latest one, Butterfly IQ multi-purpose pocket size ultrasound. I have seen this instrument in my colleagues, and these are the software we can download in the iPhone, and there are attachments are available through the audio phone jack, and we can measure the sonography through this software. And Philips and Herberts also came with this mobile uniscanner, this ultrasonography like smartphone. And this is for the Neuropol echogenic needle from Equic company, Plexus needle with the latest ultrasound reflection technology. It is specifically designed for the ultrasound guided regional anesthesia procedure. Now, if you are alone to give the regional blocks, then this is Safira system, that is a safer injection for regional anesthesia. The anesthesiologist administer regional blocks and it allows the anesthesiologist to deliver regional anesthesia without relying on an assistant to actually inject it in the right pressure. And for the PG students, there is a spinal simulator for learning how to place needles for the blocks are available as TRIS 1.0. The device is essentially a representation from human with transparent tissue so that the bones of the cheek, back and spines are clearly visible. And these are the epidural space and spinal space locator instruments are available from, one is from Equic company. The sound waves means the acoustic puncture assistant device. The penetration of the epidural space is indicated by clear variation of the acoustic signals. Here the signal will decide that how much you are inside the epidural space, and they will safeguard to you. Then this Acuro Rivana company came with the first ultrasound based system designed specifically to help you apply spinal and epidural anesthesia with automated identification of the epidural location and depth. This CompuFlow epidural anesthesia system measures pressure at the needle tip. It is able to provide precise and continuous measurement of the pressure at the tip of the syringe, both helping the guide anesthesiologist when assessing the epidural space and recording the procedure for any post-op preview. And this EPIC from this polydiagnostic come with the 2.4 millimeter of the disposable epiduroscope. It is the smallest size available in the world. And these are the trolley. Why I put these slides? Because these are the typical trolleys developed by the Britain company Supera. This is oxygen concentrator which are attached with this trolley, and the oxygen no oxygen bottles are required for this, and it gives the complete trolley with a ventilator, with a vaporizer. And so this anesthesia machine is with oxygen concentrator. And these are the anesthesia depth monitor from the now Fresenius Kabi has taken this instrument. So it's a QCon and QNOX anesthesia. This was the earlier version, and this is the latest version. Then this NOL monitoring, I think Belgian company came with the nociception level monitoring. NOL guided analgesia reduces the risk of excessive use of the or underuse of opioids and associated complication. And this is typical anesthesia workstation with agent management features. It provides live monitoring of the agents in use, helps to reduce the waste, and creates a report at the end of each procedure based on the calculation of agent use. And this our Anshul company came with the two surgical glows in a glows, that is Gamex PI. The inner glows is bright green color, while the exterior one is the natural skin color. If the exterior glow is damaged by scalping, then for example, the green from the glow below suddenly pops out. It's certainly a nice safety feature for the clinician. And this is the smallest ventilator available in the world. That is only even smaller than the A4 size. The beauty is that it is used from the street to stretchers to in the air in the OT or in ICU. It supports invasive, non-invasive or transport ventilations. And you can have a pulse oximeter integrated with this ventilator. It is from the BD company. And these are the smart Wi-Fi switches and plugs for the OT gadgets to the artificial intelligence. So you can manage all the gadgets and OT lights through your smartphone only. And even the hospital light bulbs that disinfects and kills the bacteria. The light targets naturally occurring molecules called porphyrins that exist inside bacteria. The light is absorbed and are excited molecules produce reactive oxygen species inside the cell. And the 405 nanometer emitted from indigo light creates a chemical reaction inside the cells similar to the effect of the bleach. So it disinfects the our OT operation theater and outside operation theater. And these are the digital plaster, a device meant to be embedded in the ordinary plaster that includes sensor for monitoring health related data such as blood pressure, temperature, and glucose level. And the people came with the Vittigel hemostatic jet kills. It gel that stops bleeding in seconds. When directly applied to the source of the bleeding, it rapidly adheres to the wound site and stops the flow of the bleeding by creating a mechanical barrier. This allows the body to build a strong natural clot without the need for applied pressure. Then we have seen the syringe infusion pump 1 or 2, but these are the 4 in 1 stand, 6 in 1 stand. And even China company came with the 12 syringe infusion pump in the 1 stand. And this is a bio-weld one. This is a cold cautery. It's a unique device to seal surgical incision using cold plasma gas. And this is a drug releasing sticky space. This is recently introduced in 2020. It's a novel polymer technology and it is only available just now for the ibuprofen only. And this is the RIBA It developed in the Japan, and this is a robot for interactive body assistance. Though no need for stretchers or wheels. Reba is the first robot that can be lift up or set down the real human from or to a bed. It is a programmable. If you give them instruction from OT to ward, then the robot will carry the patients from that only. And this is a Striker wireless hospital bed with smart monitoring features. A new completely wireless hospital beds that spots the number of smart patients monitoring feature. When connected, the bed will stream parameters such as bed configuration, including the position of the side rails, exit alarms, and movement to hospital's information systems, so that important events can be noticed and recorded. These are the electronic underwear preventing bed sores. The electrical underpants deliver a small electrical charge every 10 minutes. It activates muscles and increases the circulation in that area and effectively eliminates bed sores, thereby saving lives. And these are the portable CT scan and portable MRI. Somatome, the Siemens Somatome on-site mobile head CT scanner. The device can be easily brought in directly into the patient's room, and thanks to its powered wheel and an onboard battery, the only one person is required to move newly CT scanner from room to room. And this is portable MRI. Portable MRI wheels right to the point of care, plug into the standard three-prong valve of it. It's operated through a tablets that wirelessly connect to the MRI machines. Hyperfin company. And these are the MRI compatible IV infusion from M-Radium 3860 Plus. It is the world's only non-magnetic IV infusion pump. It is safe to use around MRI machines up to 3.0 Tesla. The device can pump dose from 0.1 to 1400 ml per hour. And this is A-lung hemolung respiratory dialysis system. Hemolung respiratory assist system that removes the carbon dioxide from the blood, letting the